Saludos a todos. Hello everyone from the Young Epilepsy section from the ILAE. Thanks for joining us to our second webinar. Today, we are very pleased to have Dr. John Gotman. He is professor at the Montreal Institute at McGill University. He has received an engineering degree from the University of Paris, a master's degree in computer science from Dartmouth, and a PhD in neuroscience from McGill. He pioneered the automatic detection of spikes and seizures during long-term EEG monitoring, and he made his methods widely available throughout Stellate company he created in 1986, which developed and sold all over world equipment and software for EEG, epilepsy monitoring, and polysomnography. He has published over 303 peer-reviewed papers and 40 chapters. His research interest includes analysis of the EEG, mechanism of epileptogenesis, seizure generation, and spread in humans, high-frequency oscillations, and functional imaging in the diagnosis and study of epilepsy. John Gotman is chair of the ILAE Publication Council and the director of the Intermedia at ILAE. He received the Research Recognition Award from the American Epilepsy Society, the Glore and Jasper Award and of the American Clinical Neurophysiology Society, and the Penfield Award of the Canadian League Against Epilepsy. Was named as ambassador for epilepsy of the ILAE, and he received the Lennox Lombroso Lecture at the American Epilepsy Society. We're very pleased to have you with us, John. Thank you so much for giving us your time to have today a great speaker as you. Thank you so much.
Well, good afternoon, good evening, or good morning, wherever you are. I really want to thank the Young Epilepsy section of the ILAE for organizing these seminars. And I do this in the name of the ILAE. It's a great initiative, and the Young Epilepsy section is really to be commended for this very quick turnaround after we had to cancel all the congresses. And personally, I'm very honored to be invited to speak about some of my research. It's a great pleasure to be here. It's a brave new world. I understand from Diego that there are people here from all continents, everywhere in the world, and I'm very happy that we can somehow share, be together in some way at this time of separation. So let me start, and I will talk about combining EEG and fMRI to try to see the sources of deep epileptic discharges. This is the outline of my talk. First, a few words about EEGfMRI. What are the basic features of EEGfMRI? And then see how we can look deep in the brain with EEGfMRI. Then discuss the concept of a spike onset zone, and then the relationship between the spike onset zone and the seizure onset zone. So first, fMRI. This is the hemodynamic response function, which means the time course of the bolt signal at one voxel after a neuronal activation that takes place at time zero. Imagine that at time zero, there is a flash of light or a sound or a sensory stimulation. And this is what the bolt signal is going to do over the next 20 seconds. There's a peak about 6 seconds later. So you have to realize the time scale is very long here. There's a peak about 6 seconds later. There is a trough about 12 seconds later. And then after 20 seconds, the bolt signal returns to normal. And this is what we're going to try to catch. We're going to analyze all the voxels and try to see in particular the ones that show a peak about 5 or 6 seconds after an epileptic event. In our case, the neuronal activation will be an epileptic event that we can see in the EEG. One thing that is important is to remember that this measurement has a very low time resolution. And as you can see from the time scale here, if you had an activation at time zero or time zero plus 30 milliseconds, then you would get exactly the same response. You can see here we have 5 seconds. So the peak is very broad, and something that occurs over 10 or 20 or 30 or 50 milliseconds apart is not separated in the bold signal. And you will see that we actually take advantage of this feature when we use EEG combined with fMRI. So why do we combine EEG and fMRI? Let's look at a few of the main characteristics of the EEG. The EEG reflects neuronal activity directly. So this is, of course, an advantage. This is why we like to look at the EEG, because it reflects neuronal activity. It is very specific to epilepsy, the epileptic spikes, epileptic seizures. So the EEG is specific to epilepsy. It has a relatively good spatial resolution. It has a very high temporal resolution, we know. Now, it's not very sensitive to deep brain regions. The EEG sees what's happening at the surface of the brain quite well, but it really doesn't see what's happening deep in the brain. Now, let's look at the characteristics of fMRI in the same categories. The fMRI does not reflect directly neuronal activity. It reflects it indirectly through cerebrovascular coupling. So it's not a direct measure of neuronal activity. It has no specific signal with respect to epilepsy. You cannot do an fMRI and hope to find if the patient has epilepsy or not. There's nothing specific in it. The spatial resolution is very high, can be a couple of millimeters. The temporal resolution, as we saw, is very low, but it is very sensitive to deep brain regions. It's equally sensitive to all brain regions. So what happens when we do an fMRI based on EEG? It's still an fMRI, so we're measuring activity, neuronal activity indirectly through cerebrovascular coupling. But now we have an fMRI that is specific to epilepsy because we do the fMRI when there are spikes. This measurement is still high spatial resolution, sensitive to deep brain regions, and it has a low temporal resolution. So these are the reasons that we do fMRI based on EEG. You may have heard that people often say you combine EEG fMRI because fMRI has a high spatial resolution, EEG has high temporal resolution, and if you do both, you have both high spatial resolution and high spatial and low high temporal resolution. This is not the case. This is not why we do EEG fMRI. We do EEG fMRI because we can do an fMRI that is specific to epilepsy. This is really the main reason. So how do we perform an EEG fMRI study? We put the patients in the scanner with EEG electrodes on the head, of course. We scan the patient during about 40 to 90 minutes. We do a long scan because it's important for the EEG to be able to record as many spikes as possible. And so we keep the patient in the scanner for a long time. The patient often falls asleep. It's fine, it doesn't matter. It usually activates the epileptic activity, so this is okay. We have an EEG that is very heavily contaminated by artifacts because of the scanning, and I will show you some examples. But it's actually possible to remove the artifacts from the EEG. Then we can find where spikes occur in the EEG. And then we determine the brain regions that show a significant bold change at the time of the spikes. And I will explain in more detail how we do that. And then we superpose the voxels with significant change on an anatomical MRI. And we can look at the schematic here of the analysis. So imagine that this is 10 seconds of an EEG recorded inside the scanner during scanning. What you see, all these lines here are the scanning artifact. And as you can see there, you cannot see any EEG. But you can remove this artifact. And when you remove the artifact, you have an EEG. It's not of great quality, but you can find where the spikes are in this EEG. That's all you want, is to know when there is a spike. Then you're going to build a model. This is the fundamental aspect of fMRI analysis. Imagine that this is a 6-minute run of fMRI acquisition. Imagine that there is a spike that took place at this time here. If a spike took place, if the voxel is involved in generating this spike, then it should change like the hemodynamic function we just saw. This is the neuronal activation at time 0, if you like. And then there should be a change in the bold following this peak at 6 seconds, trough at 20 seconds, return to baseline. There's a second spike here, imagine. Then this is what the model should look like. So now we have a model of what a voxel should do if the voxel is involved in generating spikes. Then we measure at all the voxels in the brain. This is an example of one measurement of one voxel in the brain. You can see that it has a little blip at this time and a little blip at this time. And then we do the correlation between the model and the voxel. If the correlation is significant, then we say, if the correlation is significant, then we say that the voxel is involved in generating the spike. If the correlation is not significant, we say the voxel is not involved in generating the spike. And then we display the result on an anatomical MRI. So this is not a map of bold activity, it's a map of statistical significance, of correlation between each voxel and the model. So the voxels here are very correlated to the model, and we say they are involved in generating the spike. So these are now some examples of real EEGfMRI studies. This is a patient where you can see a right temporal spike here, T4, T6, T602. This is a patient who has large lesion polymicrogyra. You can hopefully see bilaterally here, large abnormality polymicrogyra on both sides. And we see that there is a clear bold activation, which involves part of the lesion. It does not involve the whole lesion. And it tells us that this is the region, this is the part of the lesion that is involved in generating the spike that we have here. In this region, we have increased bold at the time of the spike. This is another example, a patient with a dysplastic lesion. You see it here, it's not a very large spike, but it's a right frontal spike. On all the slides, on most of the slides that you will see, we have right on left here. This is the right side. You see the maximum activation is in the right posterior frontal region here. So this is where we have the bold that correlates best with our model, and most likely is where the spike is being generated. So now, how do we use this to look deep in the brain? And let's try to understand what we can see deep in the brain. I show you here another example. This is an EEG of a patient with a left temporal spike here, phase reversal at F7, a very classical temporal lobe epilepsy, temporal lobe spike. Here we have left on the left. So you see we have an activation very nicely in the hippocampus. You see here in the side view, nice activation here exactly in the hippocampus. Now, if we were really together and not on Zoom and YouTube, I would ask you what is abnormal about what we see here. You would probably tell me we have a left temporal spike, of course, probably comes from the mesial temporal structure. This is not surprising. I want you to remember one thing from this talk is that this is actually surprising, and I should not have this result. And let's try to understand why we have this result. So, temporal lobe spikes and hippocampal activation. If a spike occurs in the hippocampus, it is very important for you to realize that this spike is not visible on the scalp. If a spike is limited to occurring in the hippocampus, you don't see anything on the scalp. It's too far from the scalp and it gets attenuated with the distance and you don't see it, as demonstrated on many occasions. The spikes that you see on the scalp EEG reflect what occurs in the temporal neocortex. Okay, so if a spike occurs in the temporal neocortex, I see it on my scalp EEG. But if it occurs in the hippocampus, I don't see it. So why does a neocortical spike result in a mesial temporal bold activation, which is what happened in the example I just showed you? So what is the reason? So let's imagine a sequence of events here. Let's imagine that a spike occurs in the hippocampus in mesial structures. It propagates to temporal neocortex and is recorded on the scalp. Of course, we're talking here about neuronal propagation, not volume conduction. Okay, it propagates neuronally. It takes 10 milliseconds, 20 milliseconds, 30 milliseconds, whatever. It appears in the temporal neocortex, and if I have a scalp EEG, I will see it. Then I do an EEGfMRI study, and I find the bold activation that is highest in the region where the spike originated, which is the mesial structure, not where it propagated, which is the neocortex, presumably because the energy consumption is highest at the origin, where the spike started. Okay, so this is why I can see deep in the brain. Now I show you some examples here. This is 10 channels from, or 9 channels from a horizontal depth electrode aiming at the hippocampus. So these are channels from the mesial structure in the hippocampus here, and these are neocortical channels, okay? So I see a spike here in the hippocampus, and 30 milliseconds later, I see a spike in the neocortex. Yeah, I don't have a scalp EEG here, but if I had a scalp EEG, I would see this spike. And if I use this spike to do an EEGfMRI study, I would find the source, which is here. Because in fact, the bold doesn't care about this time difference, as I told you before. This is another example here. This is an electrode in the amygdala. I have a spike here. 40 milliseconds later, I have this sharp wave in the neocortical contacts, which I would see on scalp EEG. Okay. Now I show you a real example, if you like. This is a patient who had an EEGfMRI. This is the pattern that we see in the EEG during the EEGfMRI study. We have this kind of sharp wave, double sharp wave, in the frontal central region on both sides. You see on the left side and on the right side also. And so we did an EEGfMRI, and we found an activation in the primarily left cingulate gyrus. You can't see it here very well, but it's primarily the left cingulate gyrus. Now later, several months after this study, the patient underwent an intracerebral electrode investigation. Okay. In this investigation, an electrode was placed in the anterior cingulate here, left cingulate anterior. This is this electrode here. Another one in the posterior cingulate, and multiple other electrodes, as would be done in a standard SEEG investigation. So what did we find? This is, remember, after we did the EEGfMRI study. This is what we found. If we look at this left anterior cingulate electrode, these are the mesial contact from here. These are the lateral contacts from here. And this is the posterior electrode here. So we see here what we often see in the patient with focal cortical dysplasia, very frequent spikes in this channel here. But you can see that many of these spikes stay in this region. They don't propagate if you look at this spike. Now there's one spike here that propagates to the neocortex. We see this very clearly sharp wave with 20 millisecond delay. Now in this case, we have a scalp EEG at the same time. And we see exactly what we saw in our EEGfMRI study, this double sharp wave. So when we used this to do the EEGfMRI study, we found the source of this spike, which is here, deep in the anterior cingulate cortex. Okay? So this is how we can see deep in the brain, even though we use propagated activity to do our EEGfMRI study. I'll just show you a few more examples of situation like this. This is a patient with periventricular nodular heterotopia. You can see the nodule here. You see the EEG with a widespread sharp wave, burst of sharp waves in the right temporal region. Here, this is the right temporal region. which is the overlying cortex, overlying this nodule. When I do an EEGfMRI, what do I find? This is the same EEG here. What do I find here is an activation exactly in the nodule, okay? And we can see this better here. This is the activation here. This is the nodule here. But you have to realize that the EEG that we were looking at is not generated here. It's generated in the overlying cortex. The EEG that is generated here, you cannot see on the scalp EEG. But it propagates to here. Then we see it on the scalp EEG. Then we can find the bold activation where the spike started. This is another example of a patient with focal cortical dysplasia. You can see the region of dysplasia here, which I marked here in white. It's just to make it more visible here. I put it in white. This is the region of the dysplasia. The patient has spikes, small polyspikes at P3. You see here at CZ and PZ. And when we do the EEGfMRI, we find the maximum bold activation exactly in the region of this focal cortical dysplasia. But the spike that you see here were not generated here. This is too deep. What is generated here you cannot see on the scalp EEG. Okay. This is another example here with a patient who had suspected bitemporal epilepsy. The patient had bitemporal spikes, temporal lobe type of seizure, but the patient had no memory deficit, which is very surprising for a patient with bitemporal epilepsy, and no structural hippocampal abnormality. And the EEGfMRI explained these surprising findings. You can see here, this is a left temporal spike, and we have an activation in the left insula, very clearly, not in the mesial temporal structure, but in the insula that you see here. The patient has a right temporal spike that you see here, and we have an activation in the right insula, again. And the patient has sometimes simultaneous right and left temporal spikes, and we have an activation both in the left and in the right insula, as well as in mesial frontal structures. So in this case, this temporal spike is not linked to hippocampus deep source, but to an insular deep source. And this is another example. This is the work from the group of Dr. Of the group in Kyoto and Dr. Ikeda. They did EEGfMRI in patients with hypothalamic hamartomas. The spikes were recorded on the scalp, and they found the activation in the hamartoma in these patients. Obviously, the spikes that you recorded on the scalp were not generated here. They may have started here, propagated, and then been seen on the scalp. So in this case, you see even deeper in the brain with the EEGfMRI. So now, changing topic a little bit, this is the work of Dongmei An from Chengdu, who was in Montreal a few years ago. We tried to see how the EEGfMRI was able to predict surgical outcome from this interictal EEGfMRI. We co-registered the Postop MRI with the pre-op bold, and then we defined 4 groups of patients according to concordance between this bold response and the resection. When there was full concordance between the bold resection, between the bold response and the resection, 7 of 10 patients were seizure-free. When there was full discordance, only 1 patient was seizure-free. And then we had partial concordance and partial discordance where results were in between. But the main result we find here, and this is something that we have confirmed since, is that if the bold response is not part of the resection, then it's very unlikely that the patient is seizure-free. Now, removing the bold response does not guarantee that the patient is seizure-free because we don't know the extent of how much tissue should be removed. But it's clear that if we leave out the maximum, the patient is very unlikely to be seizure-free. So now we'll talk about the concept of a spike onset zone. I assume you can already guess to some extent where I'm going. I've talked a lot about spikes starting in one region and propagating, and so we can move quite quickly to the concept of a spike onset zone. Let's imagine that this big red circle is the irritative zone, which is the zone where you can record spikes in the brain in a schematic way. This is usually a large zone. Many people consider it's not so useful because it's very widespread. You can record spikes in many regions. Let's say that this is the epileptogenic lesion. This is the seizure onset zone. This is the epileptogenic zone, which is the zone that you have to remove to make the patient seizure free. But we're going to talk about the spike onset zone, which is a region where spikes originate and from which they propagate. So imagine that this is the spike onset zone. And imagine that spikes propagate in such a way that we record them in many parts of the brain. And that becomes the irritative zone, which is all the regions where we record spikes. So if I have such an irritative zone with spikes everywhere, how do I find the spike onset zone? Is it here? Or is it here? Or is it here? And what I'm trying to say is that we can take any scalp spike, do an EEGfMRI study, and then find the spike onset zone where the maximum bold is. And I could have used this spike or this spike, or this spike, it doesn't matter. I would find where all these spikes originated. Now we confirmed this study. This is the work of Huiming Ku, who is now in Japan, who spent 3 years in my laboratory. She is a neurosurgeon who did a lot of good work in EEGfMRI. We took patients who had an EEGfMRI study and we find the maximum bold. Subsequently, the patients had an intracerebral EEG study, very much like the example I showed you earlier. We averaged widespread spikes, and we tried to see if the earliest spike is in the maximum bold region. And if this was the case, it is probable that spikes propagate from the region of maximum bold, which we call the spike onset zone. This is an example here. This is a patient who had this maximum bold here. This is the scalp spike here. You can see in the right frontal region. And this is the maximum bold. Subsequently, the patient had an electrode implantation. You see many electrodes were implanted in this patient, including one electrode inside the region of maximum bold. And you can see these contacts here of this orbitofrontal electrode that was going all the way to the orbitofrontal region are inside the maximum bold. And what we found when we averaged the spikes that were occurring in many places in the brain is that the spikes that occur in these channels in the region of maximum bold occurs the first. You can see this is the first one. All the other ones in different other regions in the intracerebral EEG at the peak at a later time. Okay, so the ones that occurred first, presumably where the spike started, was in the region where we had the maximum bold. And this is some statistics. When we average widespread spikes in intracerebral EEG, we have here a difference in latency between the main channel, which is the one that is located in the maximum bold, and any other random channel. And whether we use the peak of the spike or the onset of the spike, we have a very big difference in time between the channel in the maximum bold and the channel outside the maximum bold. So we conclude that when widespread intracerebral spikes are averaged, the spike recorded at the contact closest to the bold maximum is more likely than spikes at other channels to be the earliest. And therefore, it marks the spike onset zone. Now, this is another study which is an indirect confirmation of this idea, if you like. And this is a study that was done by Carolina Coelho Oderis and published a few years ago. what we did in this study is we took patients with an MRI-defined epileptogenic lesion. So only the patients in whom we could define what seems to be an epileptogenic lesion. We separated the lesions into deep lesions, intermediate lesions, and superficial lesions. And then we evaluated whether spikes on the scalp EEG, also ripples, but this is secondary for our purpose here, were present in the scalp EEG as a function of lesion depth. And our hypothesis was that spikes and ripples are more likely to be found in superficial lesions. And that if the patient has a deep epileptogenic lesion, we probably will not find spikes very often in these patients. What we found, however, was not the case. This is the presence of IEDs and ripples as a function of lesion depth, deep lesions, intermediate lesions, superficial lesions. You can see the presence of spike is independent of the depth of the lesion. This is not the case for ripples, which are almost only present in superficial lesion, are not present in deep lesions. So we concluded from this study that spikes propagate from deep lesions, but ripples do not. So when you have spikes in the scalp EEG, it tells you nothing about where the spike onset zone is. It could be superficial or it could be deep. Okay, when you record ripples in the EEG, most likely the epileptogenic lesion is superficial, because in deep lesions, ripples very rarely propagate to the scalp. So now to the last part. Assuming that the spike onset zone exists and is represented by the peak bold, which is what we have been discussing now, why is it interesting? Why is it good at predicting surgical outcome? We don't really care about the spike onset zone. The question is, how does it relate to the seizure onset zone? Because that's what we're really interested in. So this is another study that was done by Huiming Ku. And the question that she asked was, is the spike onset zone a good indicator of the seizure onset zone? So we took patients who had an EEGfMRI study followed by electrode implantation. And we assessed the correspondence between the region of maximum bold, the spike onset zone, and the seizure onset zone, which we recorded with the intracerebral EEG. We superimposed the pre-implantation bold map and the electrode positions, and we defined concordance if the contacts of seizure onset were within 2 centimeters of the peak bold. And I'm going to give you just the results in general. In 77% of 31 patients, the spike onset zone corresponds to the seizure onset zone. In about a third of the patients who had a specific bold pattern, which I will show you shortly, the spike onset zone determines with almost certainty, 93%, the seizure onset zone. So in some patients, we find the spike onset zone and we're able to say it's almost sure that this is also the seizure onset zone. And this is where you can see on this graph here, distinguishing a primary cluster, a bold cluster, with high probability of being the seizure onset zone. And that cluster must have a high t-value, a very significant change in the bold, and a large difference with the next highest cluster. So what we draw here is here the t-value of the peak, and here the t-value difference between the peak and the next highest value. So if this difference is large, that means that this peak is isolated, it's by itself somewhere. The next peak is much lower, okay? If this value is low here, that means there are several peaks that are approximately the same t-values. And what we found was that in this group of patients, when either the t-value was large or the difference was large, or both, which is this part of the plane, then in this group of patients, we had the 93% probability of concordance between the maximum bold and the seizure onset zone. So, to conclude now, spikes often propagate large distances in the brain, hence the appearance of a large and non-specific irritative zone. This is why very often people say the irritative zone is not so useful, because we see spikes in many places in the brain and it doesn't tell us very much. However, the region from which spikes start may be the region with the highest energy consumption, hence a region findable by fMRI guided by EEG. This spike onset zone often coincides with the seizure onset zone, as we demonstrated. So these are, I think, the consequences for implantation in surgery. If it is decided to implant electrodes, the maximum bold provides a strong hypothesis regarding the seizure onset zone. And this is important because intracerebral electrodes explore a small fraction of the cortex. It's always difficult to know where to put depth electrodes. Do we have a good chance to find the seizure onset zone? So the maximum bold can tell you, put an electrode there. It's not sure, but it's one of the good targets where you have a good chance to find the spike onset zone. In patients with very high probability that the spike onset zone is the seizure onset zone, in the group that we saw, maybe it's not necessary to implant electrodes. I'm sorry. Maybe this group of patients, you can say, well, maybe there was a lesion and you find the maximum bold exactly in that region, and it's very specific for the seizure onset zone. Maybe you can decide, if you were hesitating whether to implant electrodes or not implant electrodes, maybe you can decide it's not necessary to implant electrodes. So I want to conclude this talk with thanking the patients who took part in these studies. My collaborator for many years, Dr. François Dubois, a neurologist, epileptologist at the Neurological Institute, some of the fellows who did some of the work that I did, people, research assistant and research associate, and our funding sources. Thank you very much.
Thank you so much, John, for your talk. It was excellent talk and very educative. Actually, we have fulfilled all the objectives from the ILAE Academy, which are interpret topographic voltages maps to recognize the different types of EEG recordings and methodologies, to decide when to conduct a specialized neuroimaging and which type of functional, metabolic, or post-processing methodology should be applied, and interpret and apply the results of a specialized neuroimaging accurately in the clinical context. So with this, we have some questions, and we have actually one question which is asking is there any correlation between HFO and EEGfMRI? And if it is any correlation, what is this telling us, this correlation?
So the question is, is there a correlation between HFO and EEGfMRI? It's a very difficult, Correct. It's a very interesting question, and something that I got interested in very many years ago, but it's very difficult to study because, as I showed you very briefly, the EEG that we record during an EEGfMRI study is very much contaminated by big artifacts from the scanner. In order to remove this artifact, we have to do a lot of EEG processing. And we can remove most of the artifact, but to really clean up the artifact properly, we have to also use a low-pass filter. And we usually put a low-pass filter at about 50 Hertz, because if we don't do that, there remains some artifact from the scanner, which is very fast artifact. So when we put a 50 Hertz low-pass filter, we remove all HFOs in the scalp EEG. So we cannot do an EEGfMRI with the HFO in the scalp EEG. As you know, you can record HFOs in scalp EEG as well. So we did a study which was very interesting. This was done by Firas Faoum from Tel Aviv, who was visiting Montreal several years ago. And what we did is that this was Firas's idea. We found patients who, during the telemetry, not during the EEGfMRI study, had very frequently HFOs at the time of their spikes, of their scalp spikes. And then we found patients who had never had HFOs at the time of their scalp spikes in the telemetry where we could record HFOs properly. And then we scanned these patients and we assumed, even though we could not see the HFOs, we assumed that the ones who had shown a lot of HFOs during the night also had HFOs during the MRI scanning. And the ones who showed no HFOs during the night also showed no HFOs during the scanning. This is an assumption. We have no evidence. And then we grouped the two groups together and said, is there a difference between these two groups? And we were very surprised, and I still don't have a very good explanation, but we had a very clear result, which was that the patients who had HFOs in their scalp spike EEG most often showed an ipsilateral thalamic activation, which we did not expect at all, but it occurred in, I think, 11 of 12 patients. And in the patients that showed no HFO, I think 1 or 2 only had a thalamic activation. So it was a very strong result, and we don't have a good explanation, except that possibly, of course, we know that thalamocortical mechanism may be involved in the generation or facilitation of spikes, and maybe they're more involved when the spikes include some HFOs, but this is only a hypothesis.
Okay, thank you so much. I have another question. In order to find the ripples related to the deep sources, do we need to change the filters as usually used to enlarge the epoch? Are there any modification by others filters that is normally used?
I'm sorry, could you start again? I missed the beginning.
Is somebody's telling that if to find the ripples related to deep sources, do we need to change the filters that we usually use and enlarge the epoch?
No, as I said, we the ripples. If you want to record the ripples, you have to use a high sampling rate, preferably 1,000 hertz, and the filter higher than 500 hertz. And you cannot change that. You will only see the ripples if you use this kind of filtering. It doesn't matter if and as I showed in the study where we compared deep sources and superficial sources, you only see ripples in the scalp EEG in patients who have superficial sources, because I showed you very clearly that the spikes can propagate from deep sources, but the ripples usually do not propagate from deep sources. So you really, if a deep source generates a ripple, you will only see them with depth electrodes. Most likely you cannot see them with a scalp EEG.
Okay, thank you so much. We have another question. Do spikes with HFO have different bolt signature compared to spikes without HFOs?
Well, so this is what I was just saying earlier. This is, I think, the same answer or a similar question. The spikes with HFOs, of course, as we recorded on the scalp, because all of what I've told you about is relating scalp events, scalp EEG events with a bolt signal. So the spikes with HFOs, as I said, the difference in their signature was that they were more often associated with the thalamic activation than the spikes without HFOs.
Good.
Now,
There's
I can add something that there has been, there is a couple places that have done studies combining intracerebral EEG with fMRI. And then you can look at intracerebral EEG and the bold response to intracerebral EEG spikes. This is very complicated to do technically because it's dangerous. It can be dangerous to do intracerebral EEG, to do an MRI with intracerebral EEG, so you have to be extremely careful. But I have never done this kind of study myself.
Okay, there's another question from Mexico. It is telling how difficult is to do this protocol EEGfMRI. Can you do this with a common electrode setting?
So it's not so it's not so simple. Also, at the same time, not so complicated. You have to use special amplifiers. This is the main thing, because you have to use amplifiers that are MRI compatible, that can go in the MRI scanner, and they're specially developed amplifier that are MRI compatible. The electrodes and the wires have to be all, you can use silver electrodes, copper electrodes, it's okay because they're not magnetic. And but the problem is the amplifier. You have to use a special amplifier. Once you use the special amplifier, then the protocol is not so simple, because what you have to do is put the electrodes on the patient before you put the patient in the scanner. And in the scanner, the patient has to be completely immobile. So you have to fixate the head very well so that the patient doesn't move their head during the scan, but they're still comfortable. And then you record the scanner, you record the scan, you record the EEG. As I showed you, you get an EEG that is full of artifact. You have to analyze this EEG, remove the artifact. There are algorithms to remove this artifact. And then maybe the most difficult part really is that you have an EEG that is not of very good quality, because you have processed it, you have removed this artifact, but it's not a perfect system. So you end up with an EEG which is not very good quality, and you have to find the spikes in this EEG. And that can take a little time and can take some skill, because it's not as easy as a clean standard scalp EEG.
Okay, John. We have another two more questions, if that's okay with you. There's another question related to surgery outcome, and it's from Colombia. They want to make sure that is there any relation between maximal and maximal bolts and negative bolts related to the seizure outcome removed after surgery.
Yeah. So I have talked about maximum bold here as a and talking about positive bold responses, and these are the most common. In about 90% or 85-90% of studies, we find an increase in the bold signal in relation to epileptic spikes, and all the examples I showed you were increased in bold signals. Now, there is about 10 or 15% of cases where, surprisingly, you can find a decreased bold signal as correlated with a spike. And we think that we understand why sometimes you can have a decrease and sometimes you can have an increase. And we found that the decrease is not different in terms of its localizing ability compared to the increase. In other words, you can use the decrease. If you have a very significant decrease in bold signal, then you can use it for predicting surgical outcome. Now, there's one thing you have to be very careful about, is that very often following spikes, you have a deactivation of the default mode network. I assume many of you are familiar with what I mean by the default mode network. But if you're not, I don't really have time to explain this, but if the decrease that you see is part of the default mode network, then it has no localizing value. But if it's not part of the default mode network, then it has a strong localizing value, as much as an increase.
Thank you so much. This last question, can you please explain about the meaning of deactivation?
Of deactivation. Well, so Correct. This is the continuation of the previous question, if you like. Yeah. So sometimes we have, as I said, we have two kinds of deactivations. One of them is the deactivation that is localized to, presumably, to the epileptic region. And the one explanation, we don't have a proof of this, of course. We have one possible explanation. what we have observed, we have tried to see in what kind of patients and what types of EEG do we see more often a deactivation in the epileptic focus. And one situation where we often see a deactivation is when a spike is followed by a large slow wave. And of course, as you know, very often you can have a small spike and a large slow wave. And this leads, not always, but often leads to a deactivation rather than an activation. And our explanation is that probably what you have is first an activation that is caused by the spike, and then immediately followed by a large deactivation that is caused by the slow wave, which represents inhibition, large inhibitory potentials. That results in a decreased metabolism. But because the bolt does not have the time resolution, as I told you earlier, to separate these two events, because they occur about 100 milliseconds apart or 200 milliseconds apart, if one of them is much larger than the other, this is the one we're going to see. So we assume that it's because you have a large slow wave that you see a negative bold response. But that large slow wave is in the same region of the brain as the spike. And so it has the same localizing value. Now, the second situation in which you find a negative bold, as I said earlier, is in the default mode network. And in the posterior cingulate, bilateral frontal regions, and bilateral parietal regions. This is a mechanism we don't understand very well. It is very prominent in generalized epilepsy, in generalized spike and wave. When you have generalized spike and wave, you have a very clear bilateral deactivation of the default mode network. With focal epilepsy, you often have a partial deactivation of the default mode network. And we don't understand the mechanism of why this is happening, but it's quite common. So you have to be careful when you interpret a deactivation.
Okay, Sean, there are two more questions, if that's okay for you. I think that I'm going to take that, if that's okay. Thank you so much. There's one other question. It's called dipole orientation versus ripples. What is more sensitive to determine the superficial lesions?
Can you say it again at the beginning?
Dipole orientation versus ripples. What is more sensitive to determine superficial lesions?
Well, dipole orientation of ripples. I mean, the first thing is in scalp EEG, you find there are many patients for whom you don't see ripples. So if you don't see ripples, you cannot use ripples to localize the lesion. The dipole orientation is a reasonably good tool. I would recommend, however, that dipole model is not a particularly good model for finding source spikes. There are several methods now that use extended sources models, and I think they are better than dipole source models. So I would recommend the use of extended source models. As I said, there are several of them. But the dipole orientation can be very useful. It's always dangerous. I'm always worried about the dipole model because if you have a very widespread discharge, you can find a very good dipole fit, and it can be very, very misleading. The dipole localization can be very misleading. So if you know that your discharge is very focal, then you can use a dipole model. But if you have a widespread discharge, a dipole is a very bad model.
Thank you. And this is the last question. Is there any sensitivity value and specificity value for the EEGfMRI combined?
Is there any sensitivity value?
And a specificity value of the EEGfMRI combined?
Well, I'm not sure what you mean by sensitivity value. The problem is that the EEGfMRI has positive results in a large fraction of our patients, but we select the patients that have an EEGfMRI study. So if you were to use it in every patient, you would not have necessarily good results in every patient because one of the most important selection criteria is to only do this study if the patient has enough spikes. In other words, it's really, you're going to record this in the scanner during about 1 hour. You want to know that the patient has the probability of having at least 10 or 20 spikes during this hour. If the patient has rare spikes or has no spikes, or only has spikes when they're sound asleep, then you don't do an EEGfMRI study. So we only do it in patients who have frequent enough spikes. It's a little bit like the MEG. If the patient doesn't have very frequent spikes, there is no point to do a MEG because you will not find anything because you're limited in time. So it's very difficult to give an overall sensitivity of the method. In patients that we select for having reasonably frequent spikes, something like 80 to 85% have a significant bold response.
Thank you so much, John. We have finished our questions, and we also want to thanks again for your time and the great talk that you have given us. And please join for the next webinar.
Okay. Goodbye, everybody. Thank you.
Thank you, John.